Yep. Okay. Welcome to today's webinar and alternatives to using opioids for pain management. This is Todd Mulfenter, Director for the Great Lakes ATTC, located here at the University of Wisconsin-Madison. And this is the second webinar in our opioid prescribers series, hosted by the Great Lakes Addiction Technology Transfer Center, or the Great Lakes ATTC. Today, Dr. Michael McNett, Aurora's Director of Clinical Standards and Pain Management, will be presenting on alternatives to using opioids for pain management. And he's a presenter that's been focused on this subject for quite a while, and so we're really fortunate to have him with us today. Okay. And a little bit before I turn it over to Dr. McNett, a little bit about the Great Lakes ATTC. We're one of 10 U.S.-based regional ATTCs. There's 10 around the country now, and there's also 6 around the world. And really, this is what's happened is this has been seen as a really effective way to get webinars and technical assistance out to folks like you all who are on today's call. So the whole approach is continuing to grow nationally and internationally. The Great Lakes ATT serves Health and Human Services Region 5 that includes Illinois, Indiana, Michigan, Minnesota, Ohio, and here in Wisconsin, and we're funded by SAMHSA. About this webinar series, just to say a little bit more, it's the second webinar. As I mentioned, all webinars will be recorded and available for viewing, along with the PowerPoint slides on the Great Lakes ATTC website within the following weeks. So if you want to go back and review something or forward it to others who couldn't make it that you think it would be helpful to learn and understand, please go to the website to get these resources. Today's audio will be broadcast through your computer speakers. So if I noticed a couple of comments, people were wanting to know the passcode. It will be done through your computer, so you simply just make sure your computer audio is on. You may use the chat questions feature throughout the webinar to ask questions or add comments. The Q&A session will be after the presentation to respond to those questions. Today's presenter is Dr. Michael McNett. He is, as I mentioned earlier, the Director of Clinical Standards and Pain Management at Aurora in the Milwaukee area. He trained in family practice, but has worked in a methadone program. He's also a Suboxone prescriber, did grad work in psychology, and has a nationally known fibromyalgia center. He's published numerous studies in a book for patients. He's currently active at local, state, and national levels, improving pain management and addressing the opioid epidemic. He chairs the WMS's opioid task force and helps shape the HOPE laws, as well as the Dose of Reality campaign here in Wisconsin. He is the principal author of Wisconsin Medical Examining Board's opioid prescribing guidelines. So please join me in welcoming Dr. Michael McNett.
Thank you so much, Todd. Yeah, thanks so much, Todd. I'm really honored to have been asked to present here today, and I'm looking forward to this. I will warn those of you who are not providers of medical care that this is a little technical. When you look at the PowerPoint on the screen, I'm going to try to make this a little more accessible as I talk about it, but for those who are providers, a lot of information that you may utilize when considering using these medications will be available on the slide. So my objectives are that people, after seeing this, should be able to understand why opioids should only be used as a last resort in treating acute and chronic pain, and probably not for chronic pain at all in most patients. Why non-opioid medicines are available, and the techniques for treating acute pain, as well as non-opioid medicines and techniques for chronic pain. I've divided up the two because they are somewhat different. Aurora Health, I'm going to skip over this one. I have no conflicts of interest. So why non-opioids? For a long time, actually since about 1996, healthcare practitioners have relied on opioids as the first-line treatment for pain. After OxyContin was released, the Purdue Pharmaceuticals went on an incredibly effective marketing campaign, a kind of ruthless marketing campaign, in fact, claiming that opioids were non-addicting and that they were safe for use and that they were highly effective and that they were the answer for pain, basically marketing pain as an opioid deficiency disease in many ways. The response, and then the Joint Commission and the CMS have sort of hopped on the bandwagon and basically enforced that healthcare organizations aggressively pursue pain management, and to a large degree that was done through opioids. This has resulted in a devastating epidemic of opioid abuse, which is now a major factor in shortening the lifespan of Americans, primarily Caucasians, but to a lesser degree as well, more recently, Latinos and African Americans. So it's now clear that we need to focus on non-opioid treatments, using opioids only briefly when necessary and as a last resort. And the current guidelines, both the CDC's guidelines and Wisconsin MEB's guidelines, both reinforce this approach. So what's the problem with opioids? Well, the primary problem, besides the fact they don't really work very well for pain, is reward. I assume most people on this call are familiar with the reward system. Basically, rewarding substances activate neurons in the ventral tegmental area, which is a part of the deep brainstem area. And that then sends dopamine through an area called the nucleus accumbens, which guides motivation. So anything that activates the ventral tegmental area will cause the nucleus accumbens to motivate you to repeat that action. Well, opioids are one of the most intensely dopamine-activating drugs known to mankind. And so when a person thinks, I'm in pain, I need to take this pill, and they take an opioid, it activates that system and rewards them for thinking, I'm in pain, I need to take this pill, which causes them to think that more and more. The paradox of all this is that we give opioids to help people not think they're in pain, and yet here we are intensely stimulating at least those patients who are vulnerable to that with a reward that stimulates them to think they're in pain, and specifically that they need to take an opioid to address that. So the more that stimulus continues, the more it strengthens. In people who are mildly vulnerable, it may result in drug liking, kind of like a person that likes to have a Manhattan or two after dinner every night. But in some unfortunate people who are highly sensitive, it can spiral out of control and lead to addiction. So how is this manifested? Well, if you look at the chart on the left, the green line represents, I'm going to try my little pointer here. This green line represents opioid prescribing going back to 1999, and actually it was lower back in 1996. The orange line demonstrates opioid deaths since over the same period, and you can see how parallel these two lines are. And then when you look at heroin on the right, what we see is sort of the natural tendency of addiction to get worse over time. Addiction is a progressive disease. So as we are giving out large amounts of opioids to large amounts of people, some people are becoming addicted. It starts off with them overtaking their prescription medicines that can eventually get to the point where they get fired from their doctor and the prescriptions are terminated. Oftentimes then those people wind up turning to the streets. And so what you see is the natural progression of addiction getting worse and worse and more people getting onto the street. Then in 2010, a seminal event occurred. In 2000, and I suspect a lot of people on the line know what that was, but for those who don't, OxyContin which had been widely abused, changed its formulation. Previously, what would happen is that if a person was abusing OxyContin, all they had to do was bite through an OxyContin 80 milligram tablet, crush it up with their teeth, and they immediately got 80 milligrams of immediate release oxycodone. And that was able to sustain a lot of people's addictions. Once this new formulation came out, however, they were more likely to break their tooth than they were to break through the OxyContin pill. And so what happened is that people suddenly felt deprived of the opioid rush that they needed, and many of them wound up going to the street and getting addicted to heroin, and then you suddenly saw this dramatic escalation of heroin use, which has continued up to this day, although at this time fentanyl has risen so rapidly that in the last year or two it's overtaken it. And I think most people on the line are familiar with the consequences of a lot of this. That the things that really strike me is that every 3 weeks, as many Americans die of opioid overdoses as died in 9/11. And think about that. Think of how much our society has changed and how much money we have spent. We've fought 2 wars over 9/11. We've spent a total of over $5 trillion addressing what happened in 9/11. And this year, the U.S. government budgeted $3 billion to address opioid overdose. And yet, every 3 weeks, more Americans are dying of opioid overdose as died in 9/11. So I think what it really points out is that we really need to have a realignment of our priorities in government to recognize the severity of this problem and mount a comparable level of response to what happened in 9/11. In fact, in 2017, as many Americans died of opioids as died in the entire Vietnam War. I mean, that's just striking. The other problem is they don't really work very well. For acute pain, they're mildly effective, but not very effective, to be honest. And in chronic pain, once a patient's been on them for 2 years or more, multiple meta-analyses have demonstrated that they provide less benefit than a patient's even capable of appreciating. So essentially, they don't work for chronic pain in a way, at least not in a way that's perceptible to a patient. And this is really one of the most interesting things. And for acute pain, what they found, multiple studies have showed that those patients who get the most opioids when they're hospitalized consistently have the lowest HCAHPS scores. That's because opioids aren't very effective. Cochrane showed that an Advil and an extra-strength Tylenol is 3 times as likely to cut post-op pain in half, and that's for a wide variety of procedures, as 15 milligrams of oxy-IR. The number needed to treat is 1.7 for the ibuprofen and acetaminophen. It's 4.7 for oxy-IR. So this whole idea that opioids are great drugs for pain, really, once you subject that to the scrutiny of medical evidence, what you find is that it's completely wrong. And so what we should be doing is using ibuprofen and acetaminophen, at least in patients who can take those first. And then only if those don't work and other similar types of medicines that you could use that are non-narcotic, only then should we really rely on a drug that is so dangerous and so relatively ineffective. So as I said, for chronic pain, there have been 4 meta-analyses that have all consistently showed trivial benefits from opioids. What they found, there is a meta-analysis that came out looking specifically at how much pain relief a person has to receive from a treatment to determine that a medicine has gone from ineffective to mildly effective. And what that showed was that a patient needed to get 20 to 30% improvement before they considered a treatment mildly effective. I would say I've been very careful about monitoring outcome studies. Like when I had my fibro clinic, it was the fibromyalgia impact questionnaire. Now it's the brief pain inventory. And my personal experience has consistently showed the same thing, that if the change is less than about a 20 or 30% difference on those vehicles, patients don't think their medicines work. Well, the average benefit from opioids when used for longer than 2 months is 15%. So that shows from meta-analyses that opioids do not provide perceptible pain relief when used chronically. There are other, I did not include this, but there are other meta-analyses, or there are other population studies that have shown that going to higher doses of opioids also produces inadequate benefit, that patients on higher doses of opioids have higher incidence of adverse effects. There's actually a greater than linear increase in overdose deaths. At 100 morphine equivalents, the annualized risk is 880%. At 200 morphine equivalents, it's 2,400%. You know, if it were just linear, it would be 1,760%. So what we see is a greater than linear increase in adverse effects as you go to higher doses. And also those people are more miserable, they have lower quality of life, more depression, more disability, less likely to get off opioids and out of chronic pain. So the population studies are all consistent, and a number of them have been done showing that these patients are not getting the benefit that we're looking for from these opioids when going to higher doses. So given that fact, what should we do? How do we approach acute pain knowing this new information? Well, first of all, we should use all reasonable non-opioid treatments. That means treatments that are accessible, treatments that are affordable given the patient's insurance and what expendable income they have, and treatments that would reasonably be expected to be tolerated. If those non-opioid treatments aren't effective, then we would add opioids, but we would do so at the lowest dose possible to make their pain tolerable, and we would use it for the shortest duration possible, and we would avoid oxycodone. I will say there's a study that was done, and I should have put a slide in about that, but the study was done on people checking into rehab. And what they did is they looked at what drugs those patients admitted to being abusing at the time they're checking into rehab. And then they looked at every patient checking into rehab in the entire United States. Apparently there's a database that all this goes into. Then they divided the number of times an opioid was cited by the number of prescriptions written for that particular opioid. What they found was if you write a prescription for oxycodone, an oxycodone preparation, that patient is 2.4 times as likely to wind up in rehab abusing that drug as they are if you write a prescription for hydrocodone. And in my mind, hydrocodone and oxycodone, well, it's known that hydrocodone and oxycodone are equally effective if you compensate for the dose, because 10 milligrams of oxycodone is 15 milligrams of hydrocodone. So as long as you give an equianalgesic dose, they're equally effective. And it's unethical, in my mind, to write a prescription for one drug when another drug is much less likely to have a life-threatening adverse effect, which is opioid abuse and addiction. So that's why oxycodone was put in the Medical Examining Board guidelines as being something that should be avoided. And then if pain persists for longer than expected, we should be checking, oxycodone 10 is equivalent to hydrocodone 15. Same for morphine. What you have to do is multiply a dose of oxycodone by 1.5 to get the equivalent dose of either hydrocodone or morphine. And then if you do have a patient that has an acute problem and they've needed an opioid in addition to the non-narcotic treatment you're providing, but that pain goes on longer than it should for that particular condition, first thing you should do is look for a complication of the condition. Maybe they had abdominal surgery and now they have an infection or dehiscence, or maybe they had a fracture and they've got a non-union. So you want to look for a complication, but if no complication is present, we have to be concerned that it's the reward effect of the opioid kicking in, and that makes it imperative that the patient be weaned off opioids and onto the non-narcotic medicines that we would use for chronic pain. So I'm just going to, this is a brief list. I'm going to spend the rest of this time going into nauseating detail with all of these medicines and some other things. But so common alternatives to opioids include, for acute pain, include acetaminophen, non-steroidals, SNRIs, although those are used more for chronic pain. Tricyclics also used more for chronic pain. Anticonvulsants can be used for both. Topicals, procedures, physical therapy, OT, braces, stimulators, and cognitive and the behavioral health components, CBT, hypnosis, stress-relieving mindfulness meditation, acupuncture. All right, now we're going to talk about acute pain and the non-opioid treatments that are available for that. So first of all, Tylenol, acetaminophen. People tend to really discount the benefit of acetaminophen because it's available over the counter. How good can it be really? Well, it turns out it's actually highly effective. There is now an IV available, but it's pretty expensive. Rectal suppositories are also available, but that requires that you have a patient willing to use them, and it's like, what I usually find is, oh, no, I'll take it orally, doc, that's okay, you know. I'll hold it under my tongue until it dissolves if I have to. So the dosing, generally, for brief, like 1 or 2 days, you can go up to 6 grams a day. You shouldn't do that more than a day or two, though. Chronic, you try to keep it below 3 grams a day and never go above 4. What you find is the higher the dose you go to, the more people develop liver problems. And then you have to be aware, if a patient's on acetaminophen with hydrocodone, you have to be aware and add that to their total daily dose of the acetaminophen. And then if the patient has poor liver function or is a heavy drinker, you want to try to be very careful with this or avoid it altogether. Mildly increased liver function tests, less than double, are a relative contraindication, but if they're higher than that, you should probably avoid it altogether. And one of the things, you know, we often underestimate how much our patients are drinking at home. So I think the rule of thumb is generally take what they say they're drinking and double or triple it. Non-steroidals, ibuprofen, Aleve, and all their prescription analogs are also very beneficial for acute pain, primarily because acute pain is usually associated with some sort of tissue trauma, and that tissue trauma involves inflammation. And so not only do they provide their analgesic effects, but they also provide their anti-inflammatory effects. And so they tend to be very beneficial for most forms of acute pain. On the other hand, there are certain situations where we need to be very cautious or not use them altogether. One of these is if you have patients that have risk problems for kidney issues, like history of hypertension or cardiovascular disease of other kinds. Because as you lose your kidney tubules, what happens is that the tubules that are left increase the pressure in the blood vessels that are filtering the blood and causing the fluid to go through the capillaries and into the kidney tubule. They do that by constricting the blood vessel coming out of the kidney. So it's like stepping on a garden hose. The pressure behind where you step builds up, and that's what happens in the kidney. And so as the pressure builds up, it causes more fluid to go into those tubules that are still working. The problem is that drugs like ibuprofen and other nonsteroidals block that effect. And so the kidneys can't compensate for injury. And oftentimes what happens then is that a patient that seems like they didn't have any kidney problems, actually suddenly you realize they do, and they're a problem. And it can mess with other drug metabolism and elimination and things. So you have to be careful in patients and probably avoid these altogether if a patient has over stage 3 kidney disease, and be very careful and monitor them if they have stage 2. In those cases, you'd probably consider acetaminophen or tramadol instead. Although it is important to note that if their kidney function is stage 4 or worse, then you need to cut their tramadol dose in half. The other thing they can do is they can cause ulcers. And the reason for this is that the stomach, the fluid inside the stomach has the same acidity as battery acid. The reason it doesn't digest the stomach is because the cells that line the stomach release this, have this mucus that is hard for acid to get through. And then even if it does, there's bicarbonate underneath that binds to the acid and turns into carbon dioxide and water. So you've got this thick layer of mucus that keeps most of the acid from getting through, and any that does gets neutralized by the bicarb. Making those requires prostaglandins, and medicines like ibuprofen and other nonsteroidals block prostaglandins. And so what they do is they basically denude the stomach of its protective layer, leaving all of those cells open and vulnerable to that battery acid that's inside there. So in any person, so anybody that's prone to problems needs protection, and basically that means you need to give them medicines, they're called PPIs, that completely block the production of stomach acid. So if a person has a history of ulcers, if they're over 50, because what happens is that the nerves that carry the pain from an ulcer tend to short circuit as we get older, and by the time we're 50, a lot of people have numb stomachs and can't tell they're getting an ulcer. If they have a history of any kind of nerve problem that makes it more likely those nerves have short-circuited, and diabetes tends to cause that as well. So if they have any of those indications, they definitely should have gastric protection, and opioids should not be used in patients with a history of bleeding problems, history of a bleeding ulcer. They're allergic to aspirin because it means they're more likely to be allergic to these drugs. These all were derived from aspirin. If they're on any kind of blood thinners, and then if they have the kidney disease I talked about before. One other thing to be aware of is that these medicines are associated with an increased risk of heart disease, and that depends on the medicine. Different medicines have different levels of that, so it's important to look up the medicine you're considering to see how likely is it to cause heart disease. Indomethacin is very high. Celecoxib or Celebrex is basically does not have any increased risk, and the others are somewhere in between. And they can cause some bleeding problems too. These are the most the commonly used nonsteroidals fall into categories. There are different categories, and these medicines, you can see patients develop a tolerance to it. It seems to wear off. Its benefit wears off after a few months. If that happens, sometimes changing to a medicine that's in a different group can be beneficial. So if you're a person who prescribes these, I'd recommend keeping this slide around where it's easy to find, and use it as a reference for maybe considering switching between classes if you see people wear off. Okay, moving on to muscle relaxants. A lot of acute pain and a lot of chronic pain also is associated with an increase in muscle tension. That's kind of a residual of an old primitive reflex we had, which kept us from bleeding to death if we were hurt. The problem is that in the 21st century, most people aren't bleeding when they have pain, and so it's not very helpful for that. And so it just tends to, by having their muscles tight, those muscles get sore, which then just adds another layer of pain to the pain they already have. So if they have this, tender, tight muscles, it's helpful often to help those get out of spasm. Massaging yourself is a good way of doing that. Heat tends to help relax muscles. And then there are three medicines that I think are very helpful for this: baclofen, tizanidine, and metaxalone. Those work primarily by interfering in the spinal cord reflex that causes those muscles to tighten up. They do have drowsiness as a side effect, but it's a side effect in these medicines. The original medicines that came out back in the 70s and 80s worked by making you drowsy. The theory of back then was, well, if you're drowsy, you're not going to be tense, and if you're tense, your muscles aren't going to be tense. The FDA was very forgiving about indications back in those days. But they work mostly by sedation, and so the sedation tends to be a major problem with a lot of these, and so I recommend avoiding those. And it is worth noticing, too, that Flexeril, cyclobenzaprine, is actually a tricyclic. It's amitriptyline with one double-bonded carbon, or one carbon double bond. Otherwise, its molecule is identical to amitriptyline. So you have to be kind of careful, and it is on the Beers criteria like the tricyclics are, so you have to watch that. And what you find is a lot of times people in chronic pain get put on other antidepressants for their pain, and so you don't want to be adding Flexeril to that, because you can get into prolonged QT prolongation and other side effects. And then there are two that I recommend avoiding altogether. Carisoprodol has gone through a period where it was very, very popular, also known as Soma. That is a prodrug for a drug called meprobamate. I like to say my grandmother, when she was nervous, she got phenobarb from her doctor. My mom got Valium. In between, there was meprobamate. And Valium replaced meprobamate because it was less addictive and safer. So that gives you some idea about how heinous meprobamate is. And I commonly see patients come in who have really strong evidence of addiction, and they're on high doses of oxycodone, and they're on amphetamines, and they're on benzodiazepines, and guess what else? They're on carisoprodol. And so I think it's important to avoid that. We never prescribe it in our pain program. And then dantrolene is a drug that is a potent muscle relaxant, but it also causes a lot of liver problems, and it's used primarily by neurologists for most for cerebral palsy and other kind of conditions like that. Okay, anticonvulsants have not usually been used for short-term pain, but what they've found is that they are helpful if you use them prior to surgeries. That adding gabapentin or pregabalin pre-op often causes a significant reduction in the need for opioids and the amount of pain experienced after surgery. So even though we traditionally thought these took, a month, 6 weeks to really kick in, we're finding that it doesn't take that long for surgery, and there may be benefit to using them for other shorter-term pain conditions as well. What they do is they block the nerve that's carrying the pain from talking as loud to the next nerve. They block the neurotransmitters that it releases to activate the next nerve. There are common side effects from them, and I'm going to go into each of them in a second, so I'm not going to go through those right now. Gabapentin, I not uncommonly see patients that are being given 100 milligrams of gabapentin at night. You might as well crush it up and sprinkle it on their head as fairy dust, because that kind of a dose is almost never going to be effective. I do recommend people get them up to 900 to 1,800 milligrams a day if you're going to put them on it, and try to do that fairly quickly. What I do is I have them increase it by 300 milligrams a night over 6 nights until they get up to 1,800 milligrams. It may make them drowsy, but if it doesn't last too long, the net effect is that it helps them sleep better. And then once the drowsiness is worn off after a few months, you can redistribute it out during the day. Some patients may require to go up slower. They may get a lot of grogginess that lasts through to the next morning. And in general, if you can't get them to 900 milligrams a day, they're probably not going to get much benefit from it. And so in most cases, you're going to find yourself stopping it. And then it's common to get drowsiness. That's why I like to use it at night, because if they get it at night, it turns into a positive side effect and not a negative one. But they can also get dizziness, some weight gain, and blurred vision. And it's exclusively given out by the kidneys. It's not really metabolized. So if a person has 80% renal function, you'd probably want to reduce your dose by 20%. Pregabalin or Lyrica has recently gone generic, so it hopefully will be available without having to do prior authorizations and things fairly soon and get paid for by more insurances without problems. It's typically dosed as 300 to 450 milligrams a day. I typically titrate them by increasing it 50 milligrams each week for the first month, and they go to 150 twice a day and up to 3 times a day if necessary. Some patients may need to go slower. I will tell you that if you have patients that you have to go really slow with, even at low doses, the likelihood they're going to get cognitive dysfunction before they get benefit is very high. So if you find that you put them on even low doses and they get drowsy from that, that drowsiness will usually wear off after a month, which lets you go up a smidge, and then it wears off in a month and you go up another smidge. But if you have to start doing that at really low doses, it may not be worth the effort. For preemptive analgesia, it's 150 to 300 milligrams, usually starting 3 to 7 days pre-op, although there are some protocols that are doing it starting the night before. They tend not to be as effective. Side effects, here you see more weight gain than you see drowsiness. The lack of drowsiness was one of its selling points. Unfortunately, about 20 to 30%, and in some studies even as high as 40%, see significant weight gain. And it doesn't appear to be due to increased appetite. It appears to be somehow they're just socking it away instead of burning it. And so what you want to, then again, with pregabalin, it's exclusively given out by the kidneys. You get rid of it by peeing it out. So if you have a reduction in kidney function, you want to reduce your dose comparably. Topicals can be beneficial, although I will tell you they don't work very well for pain that's very far from the skin. So they're almost completely ineffective in most patients for low back pain if it's spinal, because it's just too far to absorb it through the skin, through the subcutaneous fat, through the muscles and tendons, and then into the area where all the bones are and stuff. That's just a long way to travel, and in general what's going to happen is the capillaries are going to grab it and carry it away before it ever gets that far down. So it works quite well, however, for bursitis like in the elbow or an ankle. If you have myofascial pain in the neck or shoulders, the knee, because there's not a lot, in most patients, unless they're really heavy, there's not a lot of adipose tissue between the skin and the knee joint. So you can get benefit in the knee, elbow, hands. Rheumatoid arthritis patients get a lot of benefit from these kinds of medicines. So the medicines that we use include an anesthetic, lidocaine, also the non-steroidals, comes in various types and forms. Capsaicin I've never used very much. I know some people who do. I consider them saints for having the patience to gradually titrate people up on. And then if you're off of it for more than a few days, you have to do it all over again. So it's and it does really burn when you have to do the titration. There is one prescription medicine that you actually numb up their skin before you apply it, called Zostrix, and so that might have some value. I haven't really used it much myself. The salicylates, they're all derived from oil of wintergreen, and so they all have that profound locker room wintergreen scent, things like Bengay. And then you can have compounded topicals, which include all kinds of medicines, ketamine, gabapentin, lidocaine, and oftentimes they're in some sort of vehicle that helps them penetrate the skin better. Some even add DMSO to just carry them right through the skin into the subcutaneous tissues. The advantages of topicals is that you don't get a lot of systemic side effects. Oftentimes, I've used these commonly in people that have stage 2 or 3 kidney disease, because the blood levels of these are like 100th of what they are if you actually give a person a prescription. And so they just don't absorb enough into their blood to have that much effect on the kidneys. So I've found that using the non-steroidals for knee arthritis in patients that have kidney problems can be quite beneficial. I do monitor them to make sure that they're not getting problems, but it's rare that I have to stop it. Disadvantages are that they're often quite expensive. They're often, again, if it's deeper tissue stuff, they're of limited benefit, and they can be quite messy to use. And oftentimes what you find is the patches don't stick that well, so that can be kind of a problem too. Physical therapy is another thing that can be very beneficial, and here we're moving out of medicines themselves. And I like to use multimodal therapy. I like to include physical therapy in that for most conditions. It's probably not that great for neuropathies, if like diabetic neuropathy or something, but for a lot of acute pain conditions it can be very helpful. And what I want you to get from this slide is that there are a number of different modalities that can be done. So it's not uncommon that I have patients come in and see me and they say, well, I've been to physical therapy, it didn't work. And I said, well, what did they do? And they say, well, they did some stretching, they had me stretch these bars and things, and then they applied some heat to me. And I said, well, they've got a whole bunch of other things they can do, so what I would recommend you do is go back for another trial, but this time tell them to review your chart, see what was used before, and ask them to use something else. And oftentimes what you find is when they use some different modalities, a lot of these patients respond quite well to that. So the failure of one round of physical therapy does not mean that another round can't be beneficial. Moving on to interventional treatments for acute pain. I will tell you, I've worked ER for 13 years, and no treatment was more rewarding to me or the patient than a patient who came in with torticollis. And I got out a syringe and I filled it with some lidocaine and some cortisone, and I gave them an injection into the muscle, and suddenly they walked out. They were in agony when they came in, and within about 2 minutes, the muscle just released, and they walked out. I had patients telling me they thought I was a god. I thought, well, you can give in the plate, please. No. But But no, it is really remarkable how effective doing trigger point and muscle injections can be for people with acute spasm. Joint and burst injections can be very helpful there as well, especially with some lidocaine and corticosteroids. Peripheral nerve blocks may be beneficial, particularly for like surgeries. Using regional blocks or infusions can be very helpful. Hematoma blocks for Colles fracture can be very beneficial. Just give the shot right into the blood clot there at the fracture site. Beer blocks have kind of fallen out of favor because what they did there is they put on a tourniquet, squeezed all the blood out, or they squeezed all the blood out of an extremity, put on a tourniquet, infused lidocaine into the extremity, and then did like an orthopedic procedure on it. The problem is when you released it and all that lidocaine suddenly went into the body, they had a lot of patients getting arrhythmias, and so they nothing like some non-sustained VTAC to scare a surgeon out of doing a procedure. So that's much less frequently used. Epidural blocks, however, are used commonly, and then if necessary, you can also do spinal blocks or infusions. Probably the epidurals are done more because there is less risk associated with them. And we all recognize our good friend Siggy here. How long have you been having these delusions? So what we find is that behavioral treatments are very beneficial, and this goes back to the whole concept that pain is a physical, psychological, and social phenomenon. And it occurs not in isolation. It's not just an anatomic issue. But as soon as that gets to the nervous system, there are a vast number of things that can either facilitate and amplify the transmission of the pain or block the transmission of the pain. We have descending inhibitory tracts that go from our brain down to our spinal cord, synapse on the dorsal horn nerve, and hyperpolarize it to make it less sensitive to pain. It takes more stimulus now to make that same nerve discharge up to the brain than it did before those nerves acted on it. The best way to activate the descending inhibitory tracts is to think about something besides your pain. Whenever you think about one thing and you really focus on it, your brain blocks all other input besides what you're focusing on. So distraction and focusing on a television, a conversation, a book, Sudoku, crossword puzzles, anything, will help block the pain so it doesn't get past the dorsal horn and go up to the rest of the nervous system. Cognitive behavioral therapy has also been proven to be beneficial, in part because where I find it works best is when patients have completely decompensated and they're just freaking out about their pain and they're having all this anxiety. Anxiety directly stimulates the pain transmission system. And so the more anxiety you have, the more you're going to amplify your pain and the greater victimization you're going to feel from it. And so helping these poor copers get their feet back underneath them, I would say you want to have your pain, you don't want to let your pain have you. And cognitive behavioral therapy can be very beneficial with that. Stress-reducing mindfulness meditation has also been shown to be of benefit. With this, basically, you become the observer of what's going on inside of your brain, and you kind of watch your thoughts like you're watching a television set, and so you don't identify with the fact that the pain is occurring. It's almost like the pain is something outside of you, and they found that really helps to reduce how much pain is perceived. Biofeedback has been demonstrated to be quite beneficial. There's actually a thing called heart math you can get. It's in a computer it's got a pulse oximeter that goes on the finger, and they measure the distance between heartbeats. And by using biofeedback, this kind of biofeedback, it's only like $225 for a program for a computer, and it can be quite effective for pain. So it's something patients can even do at home. Hypnosis can be extremely effective if patients susceptible to it. Highly susceptible patients have actually gone through open colon surgery without any medicine at all, just under hypnosis. It was a bold hypnotist that did that to his first patient, I will say that. And then other psychiatric or psychologic treatments may be helpful too. Grief, because oftentimes going through these things can cause emotional wounds, it cause grief. Family problems can develop if the person having the pain becomes over-reliant on their partner and they're not living up to what their partner expects them to be doing as half of the relationship. And So it can create family problems, and then a lot of the time anxiety and depression can develop, which just makes everything worse as well. So getting treatment for that can be quite beneficial. Integrative techniques can also be quite beneficial. The studies proving these are of weak quality, but there's almost no downside to trying most of these, so the recommendations to do them are considered high-level recommendations. So chiropractic, osteopathic, PT, nurse manipulation. A lot of people are doing manipulation these days. Energy medicine in some people can be helpful. It's not for everybody, but some people do feel that it makes a difference for them. Physical modalities such as massage. Who doesn't like a good massage anyway? Yoga, Tai Chi, Qigong. Acupuncture can be beneficial. There are some people that benefit from music therapy, light therapy, aromatherapy. And then prolotherapy is kind of interesting. It's where they inject mannose, which is a glucose-type molecule, into a stretched out ligament. And it causes scarring that causes that ligament to strengthen and shorten, getting rid of the stretch. And you can see this to be beneficial in some cases, like with recurrent shoulder dislocations, for example, or ankle weak, people that have twisted their ankle a lot of times, and so they become very prone to getting it twisted again. That has not been systematically studied, so it's still considered an integrative medicine technique, but there is a pretty good physiologic basis for it to be beneficial. And then, as I said, because even with low quality evidence, a lot of these are considered high-level recommendations because there's very little downside to it other than the cost. And so if the patient can't afford it, obviously it's not an option. But if the patient feels that it's worth the money to pay for it, then certainly they shouldn't be deprived the opportunity of trying it. I want to just say a little bit about preemptive analgesia. This is basically non-narcotic treatments that are used for surgeries. And they found celecoxib, as I said, it's kind of a brother to ibuprofen and those types of medicine, but it doesn't cause increased bleeding the way those medicines do. Aspirin, prevents platelets from aggregating, so it acts as kind of a blood thinner. All of those other medicines are related to aspirin. Well, celecoxib is more like a cousin to aspirin, and so it doesn't affect bleeding. And so a lot of surgeons find that using that does not increase the amount of blood loss during the surgery, and so they're much more willing to try that than some of the other medicines. Gabapentin or pregabalin can be beneficial, acetaminophen, and then steroids sometimes can reduce, especially for abdominal surgery, they can reduce post-op nausea and vomiting. During surgery, giving a block right where the incision is, in some surgeries has been shown to be beneficial, in others not. Blocking the area, the nerves going to an area, is very helpful because, think about this, if you put a patient to sleep with a general anesthetic and then you do an incision and then you use some kind of retractors to hold that back. Imagine somebody cutting right through your skin and then putting a couple hooks in there and pulling your skin apart. The amount of pain going up to your spinal cord is enormous. And what happens is with that pain bombarding the spinal cord, it actually causes the spinal cord nerves to become hypersensitive. And then even after the operation, they're still hypersensitive. By doing these blocks, you keep that signal from getting to the spinal cord, so it doesn't sensitize the nerves. And so it makes a big difference in how much pain they feel afterwards. Ketamine is a general anesthetic, and they can use even low doses of it that aren't anesthetic doses will keep that sensitization from happening in the spinal cord. And then after the patient gets out of surgery, then continuing celecoxib, the gabapentin or pregabalin, alpha blockers are drugs that block the release of adrenaline from the brain or norepinephrine from the brain, and that has also been shown to help in some cases of surgery. Giving regular doses of acetaminophen and then doing some kind of a block that even persists after the surgery can also really make a big difference. There's a website called postoppain.org where they list a lot of these protocols, and if you are interested in this, I recommend going there and checking that out. The effects of this are pretty dramatic. A dramatic reduction in opioid need. We've seen patients come into the hospital, have their bellies opened up, and go through colon resections and get out of the hospital without taking any narcotics at all. I mean, it can be really dramatic. You have, because they're in less pain, they do physical therapy and rehabilitation better. They get up and walk around better, reducing the risk of DVTs. Better overall outcomes. Getting out of the hospital, the data is mixed, but what you find is their satisfaction with their hospital stay goes dramatically better. And by not needing as many opioids, we reduce the risk that we're going to expose them to developing addiction. Okay, now let's talk about chronic pain. And I will say many of the same treatments that are used for acute pain are used in chronic pain, but there are some differences, and so I want to point those out. Virtually all non-narcotic acute pain treatments can be used chronically. However, opioids may be somewhat beneficial in acute pain, but they really have imperceptible benefit in chronic pain. So my recommendation is never put a patient on opioids for chronic pain because they've been proven not to be effective, at least to a perceptible level, and they've also been proven to have dramatically increased and serious adverse effects, including death. Chronic pain also often has a neuroplastic component, a neuropathic component, because the nerves become sensitized, and so they become more and more sensitive to the pain. And in fact, sometimes even if you take away the pain stimulus, the nerves keep firing. That's why we see phantom leg pain when a person has diabetes and they have all this pain in their foot, and then they finally have it amputated. They still feel the pain in their foot because the nerve that carries that pain is just discharging on its own up to the brain. And that happens to a greater or lesser degree with all chronic pain. Acetaminophen, you have to stay under 3 grams a day if you're doing it longer term. Regional blocks are probably less applicable because it's very hard to put in a catheter and just let it sit in there indefinitely. It tends to either come loose or get infected. Nonsteroidals really they're good for acute pain because of the inflammation, but most chronic pain is not inflammatory. There are some cases, rheumatoid arthritis, osteoarthritis, do have an inflammatory component, and so you do use them for that, but otherwise they're not that beneficial. And then the psychologic treatments, the behavioral health treatments, are significantly more beneficial in chronic pain because the chronic pain wears people down emotionally, and you see a much higher incidence of depression, marital discord, other types of problems like that, and so behavioral care has a bigger role. So I showed this slide before. I'm showing it again because we do use a lot of gabapentin and pregabalin in chronic pain. They do reduce the ability of one pain nerve to talk to the other by kind of keeping it from releasing its chemicals that activate the next nerve. There are different kinds of, so that's one kind of seizure drug that's used for chronic pain. Seizure drugs work by calming down hyperactive nerves. Well, patients who have chronic pain, their pain nerves become hyperactive, and so the seizure drugs tend to be beneficial. Most seizure drugs are beneficial for chronic pain. So there are drugs that act on the sodium channel, and then there's a drug called topiramate that works on a different neurotransmitter to block its ability to be picked up by the next nerve. So what you want, so you have the drugs like gabapentin and Lyrica at the top here. Oops, where is it? Here we go. So you got the gabapentin and Lyrica up here. Then you got the sodium channel agents. And I want to point out one thing. Carbamazepine, and there's another medicine that's closely related to it called oxcarbazine, or I'm blocking on its trade name now. But those two drugs are very similar, and they are essentially tricyclic antidepressants as well. If you look at their chemical structure, it's a tricyclic antidepressant structure. But they don't work like tricyclic antidepressants, but they have a lot of the same side effects, and they can interact with tricyclics, and one of which is causing a change in the heart, the EKG, that causes a person to be predisposed to irregular heartbeats that can be fatal. So be careful if you're prescribing carbamazepine in a tricyclic, or to a patient who's also taking a tricyclic. Or you can use tricyclics for chronic pain, and you can use, carbamazepine and oxcarbazine for chronic pain, but you probably should not use those two groups together. Then the topiramate, that works by a different mechanism. It's called an this AMPA is a neurotransmitter, so what it does is it basically blocks the ability of one nerve to affect the other nerve to the same degree. It also has some sodium channel activity like these guys do. So generally, I'm sorry, I'm going to go back. Generally what you can do is you can use one group with a member of another group, but you don't want to use two different members of the same group because they're going to tend to walk on each other and you may not get as much benefit. So considerations in general, if you're going to use one of these drugs, virtually all of them have been associated with birth defects. So the problem is that by the time a person identifies that they're pregnant, it may be too late to prevent the birth defects. So if you have a patient who's on these, you want to make sure that they're referred for some sort of long-acting reversible contraception like an IUD or a Norplant or something like that. They are probably safe to use after the 10th week of pregnancy, but before that, you definitely do not want them on it. So if you have any kind of fertile young woman, young female who is at risk of getting pregnant by sexual preference and activity, you want to make sure that she's adequately protected. All of these can cause a rash. They all can cause Stevens-Johnson syndrome, but it is rare. I don't know that I've ever seen it in my own experience. Topiramate is, let's talk now about individual ones. I put topiramate on here just because it fits. It's one of the nice things about topiramate is that it actually causes weight loss as a common side effect. About 40% of people put on topiramate see at least some weight loss, and some see significant amounts. That causes people to be very willing to use it. It's a great selling point. I'm trying to figure out how I can justify getting on it myself. So I do, a lot of these cause weight gain, but topiramate actually causes weight loss. It's actually half of a weight loss pill that's approved by the FDA. They took fen-phen and got rid of the bad one and kept the good one and added topiramate, and that's approved by the FDA as a weight loss pill. So that's nice. The problem is that it causes a lot of cognitive dysfunction. Trade name is Topamax. It got the nickname Dopamax because of this. That's generally seen at higher doses, though. I try to keep my doses about 200 milligrams a day or less. Most of my patients wind up on about 150 a day, and you don't see nearly as much of it at those lower doses. It can also, it has carbonic anhydrase effects, which basically means it prevents your body from breaking down bicarbonate. And so what that does is that causes a metabolic acidosis. You build up acid in your bloodstream, which then displaces calcium from your kidneys, and that causes osteoporosis, and it can also lead to kidney stones. And then when your body tries to accommodate to that, it does so by hyperventilating, because when you hyperventilate, you make your blood less acidic. So the hyperventilation then can cause paresthesias, finger tingling, and toe tingling. You also can see fatigue and taste changes. So the best way to check to see if they're having that is check their CO2 level. If it's low, they're blowing off too much because they're hyperventilating, and that's a sign that they probably got the acidosis and that you should probably consider an alternative drug. Carbamazepine has been around forever. We were giving this out when I was in med school back in the 1980s and actually late 70s. It does have some potentially serious side effects, bone marrow suppression, and rash that can develop into Stevens-Johnson. So you need to check a CBC typically, and you also have to check drug levels to make sure they're in the proper window. So you usually check the blood level at 2 to 3 weeks, and then you check the CBC at 3 months. It takes about that long for the bone marrow changes to manifest themselves. Oxcarbazine is a closely related drug that does not have the bone marrow suppression and some of the sedation that you can see with carbamazepine, and so that's a reasonable alternative. I didn't list it here. Lamotrigine or Lamictal, it has a starter pack that you can use, although a lot of insurance doesn't pay for it. I just generally start them on 25 a day, and then go up by 25 a week for the first month, so you wind them up on 100. Then I go to 50 TID for a couple weeks, and then QID. And then actually, it's not 200 milligrams a day max, it's 400 milligrams a day max. I need to change this slide. And there is some evidence that you really need to get them to the higher doses to get much benefit in pain. Side effects, again, you can see the rash, some drowsiness. What I find personally is that it's fairly well tolerated. The other thing about lamotrigine, it seems like I see an awful lot of, a highly disproportionate number of patients with bipolar disease in my practice. Lamotrigine actually treats bipolar disease, and so one of the potential beneficial side effects is that you can help them get their bipolar condition under better control by using lamotrigine, assuming that their psychiatrist doesn't have a problem with you doing so. Zonisamide is also an option. This has the same carbonic anhydrase inhibiting effect that the topiramate has, so you need to check them for metabolic acidosis with a CO2 level. If they get tingling in their hands and feet, they probably have it. That's probably why, and they're hyperventilating, and so I wouldn't even check the CO2. I'd just switch them to something else. Okay. Then tricyclics and SNRIs, they work by activating those descending inhibitory tracts I mentioned. So what you see is, where is it? Here we go. So you hurt let's say you strain your bicep. The pain goes into the dorsal horn, gets transmitted up to the brain, and the brain goes, okay, I got it. I hurt my bicep. I'm not going to do that anymore. And then it sends signals down to try to block the pain so it doesn't have to keep feeling it. It says, instead of working out, I'm going to go watch TV. And once they start watching TV, these really get activated strongly and they stop feeling the pain. That's one of the reasons why people feel so much more pain at bedtime when they're lying in bed, because they have nothing to distract them. And so they start feeling their pain. They start paying attention to their pain. You always turn these off to whatever you're paying attention to. So when you block the inhibition, this all roars through unblocked. And so that's why they feel more pain at bedtime. But so by increasing this, that's how these tricyclics and SNRIs work. So duloxetine, the other thing is many patients have depression and anxiety. In chronic pain, it's about 30 to 40%. And in fact, there are estimates that 30 to 50% of all opioid overdoses are intentional. So it's really important to monitor patients who are on chronic opioids and who have chronic pain, monitor them for depression. The benefit is that these medicines will, as a secondary effect, treat depression. And so they can be quite effective. It's like treating depression as a positive side effect from these medicines. Now, it does raise problems because sometimes they're being treated for their depression with something else. And then you get into the whole question, well, should I switch them or shouldn't I switch them? And that's kind of a concern. I will point out there's one tricyclic I'm going to mention in a second that you can actually use in those patients. So duloxetine or Cymbalta, usually 30 milligrams for a week, then 60 milligrams. 80% of people who take it tolerate it well. If they have mildly elevated liver enzyme tests, you should monitor those. If they're more than 2 or 3 times normal, you should probably not choose duloxetine because it can make those worse. Most common side effects are minor: drowsiness, dizziness, sweating. Nausea is probably the most common, but it tends to fade in a week. That's why we do a 2-step introduction. And like I say, 4 out of 5 people do well on Cymbalta, and in general, it lowers their pain by about 1/3, according to their phase 3 trials. Venlafaxine works in the same way as Cymbalta. It activates those descending inhibitory tracts. Generally, you use the long-acting. It's called Effexor. When there wasn't a long-acting form, it got the nickname side effexor because you get actually a wicked withdrawal because its half-life is very short, and what happens is that serotonin support that you get from it just disappears, and patients go through basically serotonin withdrawal, serotonin inadequacy withdrawal. And so, and with a short-acting drug, that happened, if you were giving it twice a day, it happened before their next dose. So you want to be sure and use the long-acting Effexor XR. Start them at 75 a day for a week, then go to 150. Does have a lot of cardiovascular side effects. It can cause tachycardia. If you have females with mitral prolapse, it can aggravate mitral prolapse syndrome. The withdrawal problem can be a major, major problem, but you can treat it with one Prozac. You give them fluoxetine 20 milligrams, and that stuff takes a week or two to wear off, so they get a very nice, gentle landing with that, as opposed to the dramatic drop-off they get with the venlafaxine. It's interesting, desvenlafaxine has come out, it came out about 8 years ago or so, I think. It's called Prestique. It doesn't have the same effect for pain that venlafaxine has. So it appears that it's the, what is it, cis isomer versus des? I don't remember. It's been too long since I took chemistry, but the other isomer appears to be the one that's most effective for pain. And then milnacipran or Savella is indicated only for fibromyalgia. I've used relatively little of this because in my own experience, I have not been able to get a patient on it because of all of the cardiovascular side effects. It actually raises the pulse rate 8 beats per minute at therapeutic dose in the average patient. So you can imagine to what it does to a person who's prone to any kind of arrhythmias, hypertension, if they have mitral prolapse symptoms, and a lot of patients just get really, really hyper on it. So it tends to be very norepinephrine activating. And so if you're a patient and you can get them titrated up, it can be beneficial, particularly in fibromyalgia. And then of the tricyclics, I don't use a lot of them, particularly amitriptyline and nortriptyline, because what I've found is that if you ask about cognitive dysfunction, you get startled by how many of these patients develop it. It's just remarkable how many people have it. But Desipramine, and they are on the Beers criteria, they are sedating, so sometimes people use them for sedation, giving it at nighttime. Desipramine, on the other hand, is a tricyclic, but it has far less of the muscarinic effects, so you don't see the cognitive dysfunction and many of the other side effects. You don't see as many cardiovascular effects. Desipramine is the only tricyclic that's in common use that is not on the Beers criteria, so you can use it in the elderly. Also, it's a pure norepinephrine agent, so you can give it along with an SSRI if a patient's getting, say, Lexapro for depression and it's really helping them and they don't want to go off of it. You could just add the norepinephrine. I will tell you, though, you have to be careful if the patient's on Paxil or Prozac, especially Paxil, because Paxil reduces its metabolism by 90%. So it could really drive their blood levels sky high, and the problem with that is QTc and the risk that that will cause arrhythmias. So if you have a patient on either of those medicines, I recommend starting very low, maybe 10 milligrams. Check a blood level. If it shows that it's low, you can increase it, check it again, and just inch your way up with those. And you can work them up to a dose where they're in the therapeutic range, but in most cases, their cardiac status will remain safe. As I said, amitriptyline and nortriptyline can be used. I would just encourage you, ask them about cognitive dysfunction, because I think many doctors, I see many patients that come to me on these who nobody has ever asked them, are you forgetting where your keys are? Or ask the wife, how's John's memory here? And it's like, oh my God, he can't remember anything anymore. It's like he's senile. And so if you ask, you'll find out, but oftentimes they won't volunteer that information. And with all of these, you watch their QTc, you need to check EKGs periodically, and then avoid them in the elderly, except for Desipramine. Get a couple titrations this is for the clinicians, so if you're not a clinician, you can do your nails or something, but typically what I like to do is get people on these rapidly, especially if they're having a lot of pain. So what I'll do is I'll start them off on a gabapentin titration, 600 milligrams, a half tablet at bedtime. Every night they take a half tablet more until they get up to 3 tablets, which is a pretty midline, it's a good dose. You can go higher, but you start running into problems with inadequate absorption from the intestines, and so they may just pee out a lot of it, or poop out a lot of it. So you get them up to the gabapentin, either the 1,800 milligrams or the highest dose they can tolerate. Then you wait a week to make sure they're not having side effects. Start the duloxetine 30. After a week, they go up to the 60. So in 3 weeks, you've gotten them on 2 medications at full effective dose. And then those doses will gradually build for 4 to 6 weeks. After they get on those doses, they'll see more and more benefit from them. And then I'll see them back in about 2 months and see if we need to change their dosing or anything. If they can't tolerate gabapentin, you can consider pregabalin, carbamazepine, or topiramate. If they have problems with the duloxetine, you can consider venlafaxine or dazipamine. Okay, I'm going to talk a little bit now about hooch, medical marijuana. It's significantly effective, at least by large amount of anecdotal reports claim that it's significantly effective for many various forms of pain. There are several problems with it. First of all, it's illegal in Wisconsin and federally, and we do get our license to prescribe controlled substance from the federal government, and I think it's important to remember that. I could see if you had a rabid anti-marijuana person in Washington, D.C., they could go to the DEA and say, I want you to pull the license of every doctor that's ever prescribed medical marijuana. That hasn't happened yet, but it is something to at least be cognizant of. The other major problem with marijuana is that virtually everybody that uses it gets severe cognitive dysfunction from it. So you basically can't function if you're acutely under the influence of marijuana. I don't want my airline pilot landing when he's taking marijuana for his hip pain. It can be psychologically addicting, and there can be long-lasting cognitive effects in children, including memory issues, ADHD, and things like this. So if a patient's on it, they should not be prescribed opioids unless they live in a state where it's legal. So if you're on the border of Illinois and Michigan, or Wisconsin and Illinois, or Wisconsin and Michigan, both those states have it legalized. If the patient lives in Illinois and comes to see you, you could still prescribe opioids because it's legal in the state where they live. The problem is if they live in Wisconsin and go to Illinois to get their medical marijuana, they come back to Wisconsin and smoke it, they've just broken the law. And so that patient should not be prescribed opioids. On the other hand, CBD, cannabidiol, is a component of marijuana that has no psychoactive effects. Taking CBD is like taking an aspirin or drinking a glass of milk. It has no effect on cognitive function. And so I would recommend there's currently 145 clinical studies being done on CBD for a wide variety of clinical conditions. None of those studies, to my knowledge, have been published yet. But as the results of these studies come out, we're going to have a better and better idea of how effective CBD is. It may be that it has much of the benefit that THC has, but that you avoid the problems with addiction, psychological addiction at least, and with the cognitive dysfunction, and with the desire to use it to get high and claiming to have pain as a way of getting that. So CBD is legal in Wisconsin under the CBD Possession Act, but a patient must have a letter from a doctor saying they have a condition for which it could be beneficial, and unfortunately an APC cannot provide a letter like that. The law states a physician. Animal models do show significant benefit. Oh, I'm sorry, it's 135, not 145. But there are all these studies underway. It's important to recognize the distinction between hemp oil and CBD oil. There are a lot of things called hemp oil in Wisconsin being sold for their CBD benefit. The problem is that is illegal. It is not legal to possess CBD in Wisconsin with intent to sell. It's only legal to possess it if you have a letter from a doctor saying you have a condition it's helping you with. So hemp oil is legal under the Industrial Hemp Act in Wisconsin and is not supposed to have significant amounts of CBD in it. So if somebody is selling hemp oil claiming CBD benefit, they're either breaking the law by selling CBD, or they're committing fraud by claiming that a chemical, an oil that has virtually no CBD is going to provide CBD benefits. So basically what they have to do is if they want to get CBD, they need to go online and order it. And I strongly encourage a standardized product that labels how much is in there, so much per milliliter or whatever. That way they can titrate themselves to a dose that helps them. And it's the Wild West out there. CBD oils are coming and going all the time. You know, the doses or the costs are changing dramatically from one fill to the next. And so patients are migrating between different brands. If it's standardized, they know, even if they get a different brand and it's a different potency, they know how much to take to get the dose that helps them. And so if it's not standardized, it's just a complete crapshoot to know whether you're getting enough to do you any good. It's also important to note that the molecule CBD does not cross-react with THC on a GCMR. or a LCM, a liquid chromatography magnetic resonance urine drug test. So if they test positive for THC, either they're using THC or it's possible they're using a CBD oil that was not made with strict standards, and some of the leaves and buds were getting in with the seeds, because you get CBD from the seeds. You get THC from the leaves and buds. But if they're not careful about how they filter it, you may get a bunch of that stuff in there and it gets pressed together and they get THC. I tell patients it's your job to make sure, call the company, make sure that they don't allow any leaves or buds in with the seeds when they press it. If so, you should not have THC in your urine. And it's their responsibility to make sure there is none. And this is actually what they look like, so you can see why there would be a lot of crossover in terms of potential medical benefits. Behavioral, again, I went over these before. They're just much more beneficial in chronic pain because of the progressive deterioration in mental health that living with chronic pain tends to cause, and the stress it puts on the family unit, relationships in general, work, all kinds of things. So there's all kinds of traumas that spin off of chronic pain. Physical therapy, I'm not going to go over this again. It is beneficial for chronic pain as well as for acute pain. What is probably the most beneficial is self-care treatments taught by the physical therapist upon completion of a course, and regular, diligent continuation of those self-care treatments over time by the patient. Myofascial pain, I want to just make a point of, I think it's the most underdiagnosed chronic pain problem. Anytime you have pain in any area, your muscles around there are going to tighten up. Tightening up will cause micro tears in the fibers, which will cause development of trigger points. This is just one more layer of pain added onto the pain they already have. Injections for trigger points can be short-term helpful unless it's Botox, but that's extremely expensive. What's most helpful is to teach patients how to treat themselves. So they heat the area for 10 minutes, use one of these devices if it's hard to reach. The one on the left is called a back knobber. The one on the right is called a Theracane. I personally prefer the back knobber because you can unclip the middle of it and one semicircle fits inside the other one. It's very easy to transport. They put heat on the area for 10 minutes, pressure just below the level that causes pain for 5 minutes per side, and repeat that 3 times a day. If they can't afford one of these things cost about $35 a piece. They can use a cane if they have a cane to reach their neck and shoulder area, and then you take a tennis ball or a golf ball and you put it in a nylon stocking, throw it over the shoulder, and situate it wherever in their back they have pain, and they can walk up to a door and use their body weight against the door to do the pressure. So those are the poor man's alternatives, and I've had very, very good luck with this. Occupational therapy approaches may be helpful to help them save the skills they have, build new skills that they may not have that allow them to continue to function, and find and sometimes use artificial devices to help them with reach and things like that. It can really help improve how well they're able to function in their life and maybe get them even back to work. Integrative medicine, I'm not going to go through this all again. It can be quite helpful in chronic pain as well as in acute pain, perhaps even more so. Interventions, you've got, I'm not going to go through the individual ones because I have them all listed here. Corticosteroid injections can be helpful. They tend to cause the joint to wear out faster because they help the pain, so the person uses it more and they wear it out. When you don't have any cushion, bone on bone tends to wear it out fast, and so they actually work, which is the problem. It lets people function, and then it may cause them to have the surgery. But oftentimes, rather than having the surgery right away, you may be able to postpone it for months or years by using corticosteroid injections. The key is you don't want to do more than 3 total corticosteroid injections per patient per year, and that includes joint injections, epidurals, and any other kind of steroid they may be injected with. So it's important to do a diligent attempt to find out what other steroid injections they've received. Nerve blocks are commonly used. Different nerve blocks affect different areas, and I'm not going to go through all these, but if you're a person who might refer patients for nerve blocks, I'd recommend printing off this slide and keeping it somewhere where it's easily accessible. Epidurals can be helpful, particularly for radicular pain. It might help a torn annulus, which is the outer layer of the disc, but it doesn't help disc pain itself because the epidural doesn't reach the disc. And so axial pain caused by a disc or caused by a facet needs to be addressed separately. But it's quite helpful in many cases for pain that's of a pinched nerve that's going down the leg. Again, you can do up to 3 steroid injections total a year. You should never go over 6. I've seen patients who were regularly getting 6 or 8 a year, and they came in and they were overtly had signs of Cushing's disease. And so it's very important to keep it, preferably if possible, under 3 a year. If they have facet joints are a normal joint. It's just like a knee joint. It's got joint fluid. It's got cartilage and nerve capsule, or a capsule in there. They get arthritis just like other joints do, and it's possible to go in and zap the nerve that carries the pain from that joint and make the joint go numb, which dramatically helps that arthritis pain. So that's an option. You can do the same thing with the knee. It takes generally at least 9 months, in most cases a year or more, for that nerve to grow back, and if it does, they can just go back and zap it again, assuming it grew back in the same place. Nerve stimulation is probably the fastest growing area in chronic pain treatment. Different frequencies, different pulse rates, different burst rates, and different locations can have different effects on different patients. And so there's a lot of research going on in this. It's expanding quickly, and the use of these is expanding quite dramatically. They can even put them on the ganglia at the base of the spine and get direct effects on that. Some pulses appear to even not affect the nerves themselves. They affect the glia and the inflammatory and activating chemicals being released by the glia that's aggravating pain. You can use pumps. I'm not a big fan of using them for opioids because opioids do wear off. And if you continue pumping, you can get opioid hyperalgesia. Sometimes you can use low-dose microdosing at a significant level or at a specific level, but even then, evidence tends to indicate that that's probably going to wear off after a few months. So it might be a temporizing thing. There is one chemical called ziconotide or Prialt that's obtained from the sea snail. It can be quite effective. It's given through a pump like this. The problem is that it has a lot of psychiatric adverse effects, including psychosis, delirium, acute paranoid delusion. So you have to titrate extremely slowly to give the brain a chance to get used to it, and you can kind of minimize that. And they use baclofen for severe muscle spasm, like with cerebral palsy and post-stroke. You can do an endoscopic microdiscectomy where you put a little needle down into the spine, and then you put a sleeve over that, another sleeve over that, another sleeve over that, and you gradually dilate it out, and then you till you get to a decent size, maybe about the size of your pinky finger, and then you pull that out, and you can see right down that tube, and you can pass an instrument down that tube to take out a disc. It's much less invasive than cutting them wide open and having to sew them back together again later. And I'm not going to go over the coming attractions. You can't get paid for these right now, and so it's probably not that beneficial. Platelet-rich plasma, you see rich sports people using that to recover from their sports injuries faster. This nucleoplasty is a special device that goes in and kind of, it uses the auger basically to suck the disc out.
Hey, Mike, I'm going to jump in. This is Todd.
Okay.
You have about five minutes to go, and there is a couple of questions.
All right. Well, let me just get out of this then, because I think that these things are probably at least 5 years away. So 4 questions.
Okay. So the first question came from a comment you made earlier in the presentation, where someone would like you to please share the dosing equivalent again for oxy versus hydro.
Yes. Basically, you take your oxy and you multiply it by 1.5, to get the dose of hydrocodone. So 10 milligrams of oxycodone is equivalent to 15 milligrams of hydrocodone or morphine.
Okay. Thank you. And then the other question, and more can certainly come in. If you have more, please type them in. Is methadone effective for the management of acute or chronic pain, or does the same information apply to this synthetic opioid?
You know, methadone is interesting because it's both an opioid and an NMDA blocker, which is what ketamine does. So what that does, NMDA is a receptor that opens up to cause a nerve to learn that it's supposed to be in pain. And so when the NMDA receptor opens, that causes the nerve to become more and more and more sensitive to pain. By blocking that receptor, the nerve then starts to lose some of that increased sensitivity. It's like it has forgotten that it's supposed to be hypersensitive to pain. There is a problem with methadone, however. There are multiple problems. One is it's a dose that won't affect one person can overdose another person. So you have to be very, very careful how you start methadone, and you have to titrate it up extremely slowly. Another problem is that it causes the same change in the EKG that tricyclic antidepressants do. It changes that QTC interval on the EKG that makes you prone to potentially fatal arrhythmias. And I will say it does it to scary degrees. I have seen patients on moderate doses, not high doses, just moderate doses, who had QTCs that put them in the extremely high risk ratio. So that's another concern I think we have to be very careful with, and we have to watch their EKGs like hawks. But perhaps the greatest problem with it is that it binds the receptors that of the enzymes that break down methadone and get rid of it from your body. It binds those chemicals very weakly. So if you get put on another chemical that uses the same enzyme to break it down, the other chemical will be broken down and the methadone will not. And so what will happen is the methadone will build up in your body and accumulate, and you can either overdose on it or you can get the cardiac arrhythmias on it. And you can be completely normal. You could have been on the same dose of methadone for months or years, and you go in, and one of the drugs that does that is a drug called Zithromax, which is very commonly used for sinus infections and things. So you could be cruising along fine on your methadone. You go in the ER, the doctor gives you some Zithromax for your sinus infection, and 4 days later you're slurring your words and drooling. And you know, it's a major problem. Methadone constitutes 5% of all opioid prescriptions, but it's 30% of all opioid-related deaths. So I will tell you, every time I give methadone, it makes my sphincter spasm, and I do it for a living. And so unless you really do a lot of methadone prescribing, I would be very, very careful with methadone.
Okay. And the last question, and more questions can be sent to us after, but the last one that Dr. Mignette will be available to answer is, are you able to share any information regarding studies when you discussed linear risk being greater for risk, death, and adverse effects resulting in more misery / depression, etc.?
Yeah, and it's a greater than linear risk. So if anybody is interested in the specific studies, if you want, you can send your request or send an email through. Todd, they could send it to you, and you could get it through to me.
Yeah, or Veronica, or yes.
Okay, so just write the people that have put this on, and I can send you a copy of a PowerPoint I've put together that summarizes all of the relevant meta-analyses and population studies that show just how incredibly toxic all these drugs are. And that doesn't even go into all of it, because they've now found that there's a 62% independent increase in cardiovascular mortality, that has nothing to do with overdose in patients on opioids. That's a major, dramatic increase in cardiovascular death. They've also shown 270% increase in a variety of birth defects, a doubling of the risk of premature labor in women that are taking opioids, neonatal abstinence syndrome. I mean, there are a lot of really bad problems with opioids that that you don't get the same kind of press from that you get with the overdose and addiction problems. But they've got a lot of issues. So yes, just go ahead and write the coordinators, and they'll send that on through, and then I can make sure that you get a copy of that PowerPoint.
Okay, and we did put my email address in for people that have follow-up questions. And thank you, everyone, for your time for attending today. Mike, Dr. McNett, thank you for a very informative presentation, and really glad you're out doing this work, and we're really pleased we're able to share this with the 60 or so individuals that were involved with this webinar today. So thank you very much for giving this presentation.
Thank you. I really appreciate having the opportunity.
Yeah. All right, everyone, have a good day, and please send any follow-up questions, and then keep an eye out for the next webinar in the series that's going to have Dr. Matthew Felgus talk about when people are being treated for pain management and the like within medical practices, what are ways to identify opioid use disorders and approaches to take when that identification occurs. So please keep an eye out for that webinar. And thank you.